Hello to everyone and welcome back to my channel. My name is Tommy, I'm a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize what I learn at the university during the classes and then summarize everything for you here in this series of videos. Today we're going to start a new series. We're going to view the physiopathology, so what happens in the body in certain circumstances and certain diseases. So let's begin. Physiopathology. So let's first take a look at the illness and the sick. There is no clear definition of disease, neither there is for health. We cannot use the word normal as a standard to define disease or health. And we do not talk about diseases, but we talk about sick people. So, with this in mind, we have to say that the disease is defined in each case. Every disease has phases, and there are pathology areas for each and every one of them. Causes, which can be internal or external, this includes risk factors and risk practice, correspond to the etiology. The mechanisms of the disease correspond to the physiopathology, which is what we are going to talk about in this series. The injuries, the structural and functional injuries that can happen to the body when there is a disease, are the pathological anatomy. The symptoms and signs, which indeed are the syndrome, are studied in the semiology. In the clinic, this is what we do, is to study all these areas. Very summarized, the clinic is what the doctor does with the patient. Indeed, tries to heal him or her using these areas of the pathology. The clinical phases are four. The first one is the diagnosis, in which we have the anamnesis. These are the symptoms that the patient has and tells to the doctor. Then there is the examination, physical one, are the signs that the doctor sees in the patient, and also complementary examinations when needed. There is also the differential diagnosis, because many diseases have the same symptoms and signs, so we have to know actually what disease we are treating. Then there is the prognosis, which is the prediction of the cause of the disease. So what is the expectation of it? Number 3, it is the treatment, which can be etiologic, pathogenic or symptomatic. So based on the causes, based on the mechanisms, or based on the symptoms and signs. These 3 create the clinical history of an individual. And then there is also the prevention, which is primary, when we try to avoid the disease occurrence, and secondary, when we avoid the complications. Okay, so now let's take a look at the infection. The infection is an aggression, an incident that happens to an individual, and it triggers pro-inflammatory cytokines. The consequences are inflammation, febrile syndrome, acute phase response, and systemic response, all at the same time, plus general adaptation syndrome, acute phase reactance, and immune response. The body responds to pathogen-associated molecular patterns. These are called the pumps, and these come from the exterior, from pathogens which cause the infection. And we also respond to damage-associated molecular patterns, DAMPs. These are our own molecules that come from our own cells because they are damaged and the internal molecules come out. We respond to these two, pumps and dumps, using pattern recognition receptors, the PRR. So we have an infection, which brings pumps. Then we use the tool-like receptor, which is a pattern recognition receptor, to recognize it. We trigger cytokines. Cytokines will create inflammation. And inflammation is something local that acts on the endothelium, making it pro-adherent and pro-coagulant. Pro-adherent means that it increases the membrane receptors, so more leukocytes and macrophages can adhere to the endothelium, indeed. And pro-coagulant, it creates a clotting, a microthrombosis, to avoid the spread of the infection to the whole body. And here comes the itis noun. So this is a way of speaking in which we say that something has an inflammation. Meningitis is an inflammation of the meninges, for example. When the inflammation is not local anymore, we talk about systemic inflammatory response syndrome, SIRS. And you have this when you at least have two of these, a high temperature or a low temperature. So not in normal ranges. Fever, for example. When your leukocytes are either too high or too low. Also when there is more than 10% of immature neutrophils, and when you have either tachycardia or tachypnea. So in case you have the SIRS and you have an infection, you can develop the sepsis. And the sepsis will create a necrosis in our own cells, releasing the dumps. The dumps will trigger more cytokines, which will create more inflammation, and the cycle can repeat. Now let's take a look at sepsis in detail. So sepsis is the SIRS, so Systemic Inflammatory Response Syndrome, plus an infection, plus an organ failure. Indeed, this will trigger high quantities of cytokines, and this will make the situation even worse. The inflammatory response one can have is either insufficient, when there is a presence of malnutrition or immunosenescence, etc., adequate, which is what we want, or excessive, for example, in the sepsis or in the shock. To see if someone has sepsis, we have quick assessments, for example, the SOFA and the quick SOFA. The quick SOFA is, for example, when you have more than 22 respirations per minute, so tachypnea, plus mental disturbance, plus an arterial pressure over 100 millimeters of mercurium. When you have this, we can say that you may have sepsis. Now let's take a look at the energetic requirements inside the clinic. To calculate the caloric requirements, we use the Harris-Benedict formula multiplied by the physical activity level, which tends to be 1.2 to 1.3, so sedentary, because we're talking about clinic energetic requirements. So we are in a hospital. Our activity level is not that high. Multiplied by the stress level of a disease, for example. In this case, the sepsis has from 1.3 to 1.5. In the clinic, it's very common to encounter the kwashiorkor-like situation, which is a mixed malnutrition of both caloric and proteic. Why is this? Because in hospitals, we give serum to the patient, which contains glucose. Glucose triggers insulin. Insulin stops the lipolysis. So to maintain our glycemia, we use muscle protein breakdown to create new glucose, gluconeogenesis. So we have few calories because the serum is not very caloric, and then we also break down the protein. Summarize, we have the infection that will cause an inflammation. This inflammation, because of all the problems it can get, will cause malnutrition because we will end up here with a serum with glucose, and this malnutrition will weaken us, increasing the probability of getting a new infection. And now, inflammation. So inflammation is a reaction of connective tissue in response to an aggression that comes from either the outside or the inside, so from etiological agents. It must be in irrigated tissues where there is blood. If there is not blood, then we cannot really have inflammation. So inflammation is the activation of the immune system. We will see in a bit. In the cartilage, for example, that there are no irrigated tissues and happens an infection, well, there is a direct destruction of the tissue, a necrosis, and a little bit of neovascularization, because this is what happens when there are no irrigated tissues and there is an infection. Neovascularization. The inflammation is characterized by tumor, redness, heat, pain, and functional impotence. In Spanish, it's very easy to remember because the words are very similar. Tumor, rubor, calor, dolor, e insuficiencia funcional. Anyway, the inflammation is local and can also be systemic, as we saw earlier, but it will always start as a local one. Etiological agents can be exogenous, physical, chemical, and biological, or endogenous, immunological, degenerative, atherosclerosis, neoplasm, foreign bodies, high concentrations of CO2, low concentrations of oxygen, and also the bile. Detection of the inflammation. We use inflammasomes, and these are receptors for pumps and dumps. These are proteins, the inflammasomes, that activate the caspase. And the caspase, which is activated by inflammasomes, is the one that activates the pre-interleukin 1 into interleukin 1. Then inflammation has phases. Phase 1 is the vascular reaction, which is local, And it is done because of histamine, prostaglandin, and nitric oxide. Causes hyperemia, protein exudation, and altered spatial relation of blood cells. This is indeed tumor, redness, heat, pain, and functional impotence. Phase 2 is cellular reaction. 2.1. Early leukocyte phase. There is a recruitment, an adhesion to the membrane, and a diapedesis, a passage to the interior. So the leukocytes will adhere to the endothelium and then get inside of the cell. 2.2. There is a late leukocyte phase, which includes the chemotaxis, where the chemokines bring them to the inflammatory focus. So the leukocytes gets a taxi to the inflammatory focus. Easy to remember. Then there is the activation, and once the leukocyte gets to the inflammatory focus, it activates and produces mediators. Then there is this thing called osmoization, which is coating foreign particles. Mark them. So then there can be the phagocytosis of the marked particles. The result of all these inflammation phases is either resolution, which is good, chronification, so it persists, or necrosis, as we saw earlier in the infection. Now let's take a look at the inflammation mediators. So there are chemical and also cells mediators. Chemical characteristics are very short half-life, beneficial and harmful effects, stimulate other mediators, and multiple mediators with complex interactions. We have plasmatic chemical mediators, which will act on systems. For example, the system of complement, which creates apoptosis, which is a programmed death of the cell, not like a necrosis. Coagulation, which is meant to not spread the infection to the whole body. Fibrinolysis, to reactivate the circulation and therefore being able to repair the tissue. And kinins, that will create pain, so there is an immobilization of, for example, your arm, whatever part of your body, so repair mechanisms can occur. On the other hand, we have the cellular, which are vasoactive amines, such as histamine and serotonin, biolipids, free radicals, nitric oxide, fat-soluble enzymes, and pro-inflammatory cytokines, which are meant for communication. These pro-inflammatory cytokines are very important, and we must know them. There are the interleukins, interleukin 1, which we saw earlier, and interleukin 6, which are pro-inflammatory. But there is also, for example, the interleukin 10, which is anti-inflammatory. Interferons, IFN, and also, which is very important, this one, the tumor necrosis factor, TNF, which is pro-inflammatory, and it is correlated with cachexia. And then we also have the colony stimulating factors. These are meant for the leukocytes' growth. The most important ones of these are the interleukin 1, interleukin 6, and the tumor necrosis factor. They can create endothelial activation, fever, lower the appetite, proteolysis for gluconeogenesis, and the presence of these will lower the albumin, the prealbumin, and the transferrin, and they will increase the PCR, which is the protein C reactive, the fibrinogen, and the ferritin, which are indeed the acute phase proteins, because these, when they are present, they create an acute phase systemic reaction, leading to what? Systemic inflammatory response syndrome, SIRS, which brings us to this one. When you have fever, leukocytes either too high or too low, a higher amount of immature neutrophils, tachypnea, and tachycardia. Now, taking a look at cells' inflammation mediators, we have the circulating ones, such as neutrophils, basophils, eosinophils, lymphocytes, and platelets, and the tissular ones, so inside the cells. Mastocytes that create histamine, the fibroblasts that create fibrosis to indeed heal, and macrophages and lymphocytes. What are the actions of inflammation mediators? Well, these ones: vasodilation, higher capillary permeability, chemotaxis for the recruitment, fever, pain, and tissue damage. So since we talked about fever, let's view in detail what fever is. So as general concepts, we have to know that the hypothalamus controls the body temperature. There is this thing called thermolysis, in which we dissipate heat via radiation at 60%, via convection 12 to 15%, evaporation through the skin 20-27%, and conduction in very low quantities, since we are not really touching anything. Temperature regulation happens in two systems. Endocrine system uses the thyroid, which will increase the TRH, which will indeed increase the TSH. These are thyroid hormones. And this will eventually create thermogenesis by increasing the metabolism. The thyroid indeed controls the metabolism. And then also via adrenal medullas and the catecholamines, adrenaline and noradrenaline. On the other hand, we have the autonomic nervous system, parasympathetic, rest, and sympathetic, fight or flight. These two control the temperature. And the skin is the main part of regulation, because the thermoregulation in the skin happens using anastomosis, which are indeed junctions of an artery, a little artery, and a little vein together to skip the capillaries of peripheral circulation, for example in the hands. And when you have white hands, it's because your body used anastomosis. So instead of giving blood to all these capillaries that are present in your fingers, it skipped them and returned directly to your arm here. There is a problem when you have only a few fingers white, or maybe only one hand white. This means that it lacks blood, and this is called the Raynaud syndrome, and it can be very problematic. Now let's take a look at the definitions of fever. So the ideal temperature measurement should be inside the body, but since we cannot really reach the heart, we use the axillary one, which is the most frequent. Then we have the buccal and the rectal. The more accurate is the rectal, followed by the buccal and then the axillary. So fever is the increase of body temperature above the diurnal elevation, because you have to know that in the afternoon, for example, we have a body temperature a little bit higher than in the morning. So fever is above the diurnal elevation, and it is caused by a new set point from the hypothalamus. This is very important. On the other hand, we have the hyperthermia, which is an increase of the body temperature due to failure in heat elimination mechanisms. For example, you don't sweat, and therefore you keep your body temperature very, very high. But there is no hypothalamus involved here. Causes and mechanisms of fever. So causes are, for example, infection, which can be viral and or bacterial, tumors, lymphomas, and connective tissue diseases. The mechanisms. So we have an exogenous pyrogen, for example, from an inflammatory stimulus, necrosis, neoplasia, or an altered metabolism, whatever. This exogenous pyrogen gets detected by a monocyte. Monocyte detects virus. The monocytes communicates with the interleukin-1. The interleukin-1, which is an endogenous pyrogen, if you remember interleukins, they communicate. So this molecule needs to reach the hypothalamus, but it cannot pass the blood-brain barrier. So what the interleukin does is to go to the vascular organ of the laminal terminalis, VOLT, to produce prostaglandin E2 from the arachidonic acid using the cyclooxygenase. And the prostaglandin E2 passes the blood-brain barrier, increasing the temperature and creating the fever, because the prostaglandin tells to the hypothalamus to set a new temperature, which is higher than the normal one, and this will create the fever. So the fever is the prostaglandin and also the thromboxane, which creates a little thrombosis. And you have to know that the aspirin, for example, blocks the cyclooxygenase, so there is no prostaglandin, and there is no fever, and there is no thrombus using aspirin. So now I want to talk about hypersensitivity, autoimmunity, and immune deficiency. Starting by hypersensitivity, it is the tissue damage or functional alteration, and there are several types. Type 1 is the anaphylactic, such as allergies, for example. It is a response to innocuous antigens. In the first contact, there is awareness raising. In the second contact with the pathogen, there is an allergic response. And here, cytokines are involved. Again, cytokines. So what happens? Histamine, the main one related to allergies, that's why people take antihistamines. Anyway, histamines PAF, which is platelet aggregator factor, and prostaglandin, will create muscle contraction, vasodilation. They will increase the capillary permeability and therefore creating an hypotension. This will create edemas, and this is the real problem because a glottic edema will create an anaphylactic shock, which can be fatal. These edemas are treated with adrenaline. This will increase the cyclic AMP and phosphorylase C inhibition. In the clinic, they have to stop the anaphylactic shock. This is what they do the majority of times. And the angioedema is the most common one. What are the causes of allergies? Aerial allergens, mites, by sting, jellyfish, intravenous, for example medication or radiology, food, or the 14 allergens of food, heat or cold allergy. There is also allergy to physical exercise, a trauma, for example, and to drugs. Vancomycin will create, for example, the red man syndrome. Then we have the type 2, the cytotoxic, using IgM, immunoglobulin M, or IgG antibody. This has to do with membrane antigen. Inflammation, frustrated phagocytosis, in which we release enzymes from the cell and then these will damage the membrane. Cellular dysfunction, acetylcholine antibody will create, for example, muscle paralysis. No acetylcholine, no muscle contraction. Basically, this type 2 will attack the body's own structures, platelets, granulocytes, hemolytic anemia. An example of this is the Good-Pasteur syndrome, which attacks the kidneys and lungs, and we get a bloody sputum. Then you have to know that type 5 is antibodies to receptors, and type 6 has cells natural killer involved, which are variations of the type 2, so it attacks the body's own structures. Type 3, though, is circulating immunocomplexes. Here we have an antigen, which can be endogenous or exogenous, and an antibody accumulated in natural filters. Local, R-first type, will precipitate where they enter. If the antigen enters in the skin, then there's this hypersensitivity in the skin. If it's in the eye, then in the eye, for example. Then we have the systemic serum type, which is infectious, an infection again, and the complexes accumulate in filters. This is when, for example, we have headache, muscle pain, and also pain when urinate. There is a systemic pain overall, and chances are you probably had this once in your life, where you have pain in all your body and you really feel weak. And then last but not least, we have type 4, which is delayed or cellular. Non-immunoglobulin cell mediated, so no Igs. This is when, for example, you have sweat under the watch and your skin turns a little bit red. This is a contact dermatitis and it is not an allergy. It is an hypersensitivity. Moving on, we have autoimmunity, which is loss of immunological tolerance. It means you no longer know what is yours. It can be natural or acquired, specific or non-specific, central, for example, in the thymus, or peripheral, in the lymph nodes. Deletion, allergy, and clonal ignorance. Then we have the immune deficiency, which can be humoral or combined. Humoral is involved with B lymphocytes, low immunoglobulin A, which has to do with drugs, viruses, tumors, nephrotic syndrome. And then on the other hand, we have the T lymphocytes combined, so it is both B and T, and it has to do with live. And it has to do with viruses, the HIV, malnutrition, diabetes, neoplasms, and chronic renal failure. Okay, that's it for this video. Thank you so much for watching to you all. You can find this diagram in the description down below by clicking in the first link. It's on my website and you can download it for free. Remember to like, subscribe, and share this video to your friends and family to spread this knowledge to them as well. Because these are basic functions that our body has, and I think it's interesting for you to know. Thank you so much for watching again, and see you in the next one, in which we are going to talk about the lungs. Ciao!